Hello everyone and welcome to today's webinar, Breast Shield Sizing Translating the Evidence with Dr. Danielle Prime. Before we get started, I would like to go over a few items so you know how to participate in today's event. You've joined the presentation listening using your computer's speaker system by default. If you would prefer to join over the telephone, select phone call in the audio pane and the dial-in information will be displayed. You'll have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. There are handouts for the webinar. Please be sure to download these before the end of the live event. We previously communicated that today's webinar would be eligible for continuing education, but have a change to note. Medela webinars are designed to help healthcare providers enable their clinical practice. This webinar will connect the science to our portfolio of breast shield solutions. No CEUs will be offered for today's webinar. Today's webinar is being recorded. All of our webinars are made available through Medela University. I would now like to introduce Dr. Danielle Prime. Danielle is a member of the medical research team at Medela AG, Switzerland. One of her major roles is to keep abreast of the latest research into human milk and lactation and endeavor to communicate this knowledge both internally within Medela and externally, medical and research community. Danielle completed her PhD in biochemistry in 2010 at the University of Western Australia with Professor Peter Hartman and the Human Lactation Research Group. The focus of her research has been centered on understanding more about the basic physiology of human lactation to provide clinicians and mothers evidence-based knowledge. Dr. Prime?
Thank you very much. Thanks to everyone on the call. I'm really excited to be doing this presentation and to bring to you a nice overview of the evidence of where shield sizing is currently sitting. It's a topic very near and dear to my heart, and I'm really excited to be able to share the presentation with you. So, full disclosure, on my next slide, as I click through, there it goes. I am currently an employer of Medela AG, as the intro stated. And what I want to walk through with you today is, firstly, a little bit of a recent history about the breast shield. And so recent meaning the last 20 years, which is really the amount of time I've been working on the topic as well. Then we'll lay the foundations with the anatomy. I want to walk you through all the different anatomical aspects that we need to consider when we talk about shield sizing. Then we'll talk about sizing from two key lenses, one being performance and the other one being safety. Then we'll cover the principles of breast shield sizing and more of a step-by-step process of how to go about it. And then I'll conclude with some additional and further considerations, because any of you working in this topic are aware that this is not a very simple process to undertake. So let's look firstly at the recent history. So for me, the shield topic started way back in around 2006 when I started my PhD. And I have to say, back then, the entire globe, when it came to breast shields, was very much on a bigger is better mentality. So in the last 20 years, we've done a big flip, which is great because science is an evolution, right? There was a tendency for bigger and bigger shields to be requested from the lactation community. We had tons of lactation experts sitting down saying we need bigger shields to be provided with the pump, to the point where even a 40mm shield was provided made out of glass and glass blown by hand. And then we saw data coming from hospitals saying up to 78% of mums were needing to switch to larger shields in the first days in hospital. This is likely linked to edema, and I'll cover that a little bit later as well. And edema protocols have really reduced this in recent years. And then as part of my PhD, I had the lovely Professor Diane Spatz come down, and we worked together during her sabbatical. And we conducted what was at the time the first comparison study of shields and sizes. We selected the 24, 27, and 30 size shields to test because they were the most commonly used shields in the US at the time, which is where Diane was coming from, but of course also across Australia and abroad. And the focus of the study was about these anatomical insights. So I'll bring them forward in this presentation because we did learn a lot during that, even if we were using these very large sizes for all mums. So then in around 2014, being from Perth, and I'm in Perth right now, so please forgive me, it is 11 p.m. I'm going to do my best, it's very late, but when I joined Medela in Switzerland, I would say, perhaps slightly frustrated because there were all these sizes being offered by pump manufacturers, but there were very little fitting guidelines available and very little guidelines that were evidence-based. And so in 2014, we really saw two key things. Number one was that shields at the time were labelled with a SML/XL sizing regime. And it was really clear when we interviewed mums and HCPs that this was being interpreted as needing to match their breast size rather than their nipple size. And so that could explain why some of these larger sizes were in fashion, right? So we've got a mum with a large breast, I need a large breast shield. And that's certainly not how fitting should work. It's really the nipple size rather than the breast size that should be taken into account. And so back in 2014, this first two-step fitting guideline was created. We created it and we validated it in the US, actually. I know a lot of the attendees will be in the US for this call. We had mums tested, we had HCPs sitting there assessing the mums and whether they had used the fitting guide appropriately, and then we had them use their selected shield for a number of weeks to make sure that it had a safe basis. And it sat there, and I'll cover some of the different options available today, but it sat there since 2014 in that form. So given...
Doctor,
Yes?
forgive me, if I may ask, could you adjust your microphone down just ever so
Down?
slightly? Down, yep.
How's that? Is that better?
I believe that is, yep, let's try that.
Right.
Thank you.
Okay, so given that we were focused on the breast, then we started to dig into the breast part of the shield, which is the flange. And I'll show you some literature around the flange part of the shield because that's also essential for fitting. And in 2020, we ran a full randomized controlled trial to look at that parameter of the shield and saw that a more open or wider opening angle of the flange could very much increase milk output. And so at this point in 2020, there was now a bundle of clear literature that existed that showed that breast shield design and fit are important factors that can improve milk removal, comfort, and overall experience. So we were really on this journey, and now we find ourselves in 2024, and we see lots more endeavours popping up around shield sizing and a nice evolution of this journey. And the other part that I'll bring to you today as well is my side hobby, which is the collection of my nipple database. Because back when we did the fitting guidelines and we saw this SML/XL issue, we really started to wonder, well, what is the true anatomy of the breast? How is it that we do not have a source of nipple diameters of the general anatomy of the lactating breast available at our disposal in order to support evidence-based sizing and considering comfort, performance, safety, and complexity to really translate all of that through. And so I'll mention some of the results of the nipple database or how we've utilized the nipple database in this endeavor as well.
Doctor,
Okay.
I am so sorry to ask this again, but if you would adjust it just further down, it's picking up.
Too much?
Let's try that.
Okay, that's one down. How's that?
I think that's
All
going to
right.
be better. Thank you so much.
No worries, thanks for telling me. So let's look at the breast shield. So the breast shield has two key components which are linked to clinical outcomes. And those two key components that we can modify within a breast shield, right, are the tunnel, and that's the part that's going to fit to the nipple, and the flange, and that's the part that's going to fit to the breast. And so we know that the flange and modifying the flange is going to result in improved milk outcomes and comfort ratings. And what we saw is that increasing the opening angle was important, so to 105 degrees. So we know that that part of the shield is important. We know that that part of the shield needs to fit to the breast structure and anatomy, and we had 3D breast scans to inform that shape. And then on the other side of the equation, we have the tunnel. And when it comes to the tunnel, it's a very simple circle structure, right? So we just have smaller or larger diameters, and that's also been linked to to clinical outcomes. But if you think of the shield, there's really these two levers we can pull to improve performance and comfort for mum. We can alter the flange, so the shape and the angle of the flange, so it fits to the breast well, and we can alter the tunnel in terms of the diameter and how it fits to the nipple well. So in order to look at the unmodifiable factor, which is the anatomy, I'll now step through the anatomy of the lactating breast, because I think it's really important that we all have this common foundation of the anatomy and how it therefore fits, because this is the non-modifiable element in the equation. When you're working with your mums, you have all kinds of anatomy come to you. And what you'll see is that some things will work really well for some mums and some will not work so well for other mums. And I'm hoping by stepping you through this anatomical basis, you'll start to understand or help you build a little toolkit inside your mind that helps you to assess why some things are working for mums in certain ways and the intra and inter-individual variation. So most importantly, obviously we have the milk producing tissue shown in this image. Now this of course is that little bunch of grapes, so you can see them circling around. We know that they are both producing and storing milk. Those are in the alveoli, but let's take that layer away. If we take that away, then we reveal the really complex network of milk ducts. And those milk ducts store less than 4% of milk. So their whole job is to transport milk from those alveoli and out the nipple. And we really need to make sure that they can do that transportation job as freely and as unimpeded and unobstructed as possible. In order to show that in a little bit more detail, I'll show you this ultrasound video of a milk duct in action. So what we're going to see is this is the tissue of a lactating breast. The ultrasound probe is sitting on the outside of the breast. The nipple would be top right of screen. This here, this black line is the milk duct in itself. When at rest, it's only 2 to 3 millimeters, so they're really quite tiny. But when we get a milk ejection, and we'll see those alveoli squeeze on the other side, you'll see the response of that and the milk flow through there and the expansion of the nipple. So if I press play now, so we're not in a milk ejection yet, we're applying something at the other end, we're stimulating with fast sucking rhythms, or the baby's stimulating with a fast sucking rhythm, we trigger that milk ejection, and now we're starting to see this massive diameter increase. So these milk ducts will increase up to 68% during a milk ejection as that positive pressure pushes the milk through and towards the nipple. Where we're going to see jets of milk on the other end. And what's important to recognize is that these milk ducts live very close to the surface of the skin. They're really very superficial. And with an ultrasound probe, if you take a segment of the breast where you can see these very open milk ducts sitting here, if you simply compress that with just a mild to moderate compression with an ultrasound transducer, you can see that many of those milk ducts are completely obliterated. So compression is really something to avoid in general for mums, and the shield is a source of potential compression. Now there's this other mystery component in the anatomy, and I bring it forward because it was one of the key outcomes of what Professor Diane Spatz and I discovered during that first initial study. So this component, which is simply intraglandular fat, so this is fat that's distributed throughout the glandular tissue within the breast. This fat type is related to the total amount of tissue in the breast, so there is generally more of it if the breast is larger. But what really showed up is that when we were fitting with these really large sizes, the 27 and the 30, we saw an association that if the mums were to have mid to high levels of intraglandular fat, then they were actually performing okay with these large shields. So what we deduced is that intraglandular fat amount may reduce the constriction of the milk ducts during expression. And what I mean by that is that it kind of provides a bit of a buffer. So it allows milk to be removed more easily, and it means that those milk ducts are less susceptible to being compressed, and probably makes these mums, or the data indicated, less susceptible to a really incorrectly sized shield. So this is a really interesting kind of mystery component that I want to bring forward, because whenever we're dealing with biological data, we see these kind of outliers, or we see this bundle of mums that don't quite make sense. And I have a really strong inkling that the amount of intraglandular fat in the breast is one of those drivers that maybe means some mums don't conform to certain fitting rules or processes that work quite well for other mums. So it's really something to keep in mind, and we'll mention it again later. And I want to note that in the studies that were conducted, we didn't have a large proportion of high BMI mums. So, you know, we're still talking here about mums within a normal bell curve. And of course, if you have too much intraglandular fat, that relationship may shift. So we don't have data on that. Okay, so now let's dig into milk duct compression. So if we talk about the breast, now you can see here, here's a shield with a sharper angle that is clearly compressing the tissue. And what you see in your clinical practice, I'm sure, over the years, are these types of red circles. Things that we don't like to see. You can really see that mums are really pushing the shields quite hard into their breast. And this is simply something we want to avoid. And one way of avoiding it was to modify the flange angle. And so that's exactly what the study did that was published in 2020, where the opening angle was increased. And what we saw is that when we increased the opening angle of the flange to 105, we had immediately really positive comfort feedback from mothers. But when we presented that comfort feedback into NICUs and into facilities where, you know, in a NICU, milk is medicine, right? And what we really heard strong pushback was, okay, it's more comfortable, that's interesting, but I'm not interested until I see performance data. Because unless it's getting out equivalent or more milk, that comfort is secondary to me having milk for my premature infants. So we took that on board, and that's why we in fact conducted the randomized controlled trial on it to really assess performance, because we wanted to make sure that we didn't go backwards with offering this part or altering this part of the breast shield. And luckily, you know, overall the results were great. We saw faster first milk ejection, likely because the nipple is a bit further in at the start, and so it allows a quicker engagement of the tissue. We saw an increase in milk output and efficiency. So at every time point, that yellow bar is higher, and that was 11.8% more milk at the end. We saw an increase in breast drainage, so an overall 4% increase in PAMA. We saw statistically higher comfort ratings. So that was great. And then we had the performance data to back up that this was an appropriate shift and it could make a real impact to mums. But now let's zoom into the nipple. So we've talked about the breast now, the anatomy, and those milk ducts that are sitting in the breast are, as I mentioned, around 2 to 3 millimeters in diameter. Now the nipple that's dealing with the tunnel, it's a little bit of a different beast, right? So we have a few nice studies. This one's a really nice one. It's actually cross sections of tissue all laid up to kind of reconstruct what a nipple would look like. And what is really clear is that the ducts narrow at the tip of the nipple. They widen in the middle a little bit, but what's interesting is look how tiny they are. So 0.06 millimeters at the tip of the nipple. So they're teensy tiny compared to 2 to 3 millimeters in the broader breast, right? Then there's a kind of a 10-fold increase in diameter when you get to here. So 0.7 millimeters, but still tiny. There's a narrowing of the milk ducts into a waist here as they arrive through the areola, which is really interesting. And Professor Donaghetti's will refer to this area here as being kind of like a kind of a bunched up concertina that needs elongation. And so, you know, we do really point out here that we need elongation and radial expansion of the nipple to ensure that those milk ducts are allowed to open up and freely remove milk. So that distension becomes really important. And the application of negative pressure at the other end is obviously key. So once we get that milk ejection, it's going to push the milk through. It's going to expand all those milk ducts in diameter. We need to elongate the nipple and radially expand the nipple to make sure that that expansion is allowed. And then we're basically applying a negative pressure from a baby or a pump on the other side. And that's allowing the system to work with the positive pressure of pushing the milk through the nipple, because the nipple is we like to talk it as kind of like the gatekeeper here, right? So depending on how tight those common orifices are and those narrow tips, it also probably depends then on how much that mum is likely to leak, for example, too. So the nipple anatomy is really, really interesting. And here is another view of the nipple under ultrasound. So you can see the nipple here. You can see those ducts really quite clearly here. You can barely see them in the nipple tip as they narrow down into that tiny amount. And here's the nipple areolar junction. And ultimately, we really want to make sure that these nipple ducts can expand, and that brings to the to allow the milk to flow freely. Okay, so now let's look at nipples then. So what do nipples actually look like? So the nipple database I was referring to at the beginning of the call has been, a hobby, a little life's work in the last couple of years. But basically what I've been able to collect is through 23 different sources of data and literature from 8 different countries, 1,136 nipples. And what's really interesting across this database is that the average is around 15 to 16 millimeters in diameter. That's the average nipple diameter that we see. However, like any biological system, check out the distribution, right? So we have mums all the way down here that are as small as 9 millimeters. These are all lactating mums. This is all post-birth. And then we also have on the other end mums in this large area. And I have here just greater than 25 millimeters in diameter, but the largest in the database is currently 30 millimeters in diameter. And when I cut the database by geography or by racial or ethnic category, I really don't see a difference in the histogram profile across the globe. And that kind of makes a lot of sense when you think about the fact that breastfeeding is something that is done globally and there has to be a nipple to baby fit. So there's something conserved about this. The fact that it always pops up at 15 to 16 millimeters on average, I think makes a lot of sense from an evolution perspective. Now on the far right there, that 30 millimeter nipple, just out of interest, was actually a Caucasian mother in the US. So we don't see, any of the myths that we hear a lot about certain ethnic categories having certain qualifiers. It's just not showing up. And obviously, as we mentioned at the beginning too, so large breasts do not necessarily have large nipples. So breast size does not equal breast shield size. That's really important, and so nipple diameter is key. And so we've been using this to help inform best practice around the shields. Then nipple expansion pops up. So we know that the nipple diameter increases post-pumping, and we know that this increase is around 2 to 3 millimeters in both the length of the nipple and the diameter of the nipple. And that's shown here in the histogram. You can see here in the middle here, the most mums in terms of frequency of expansion are sitting between that kind of 2 to 3 millimeter mark. But it varies again greatly between women. We see some women all the way out here that are expanding by around 8 millimeters, and some on this end over here that are expanding next to nothing or even getting a little bit smaller. So human anatomy is incredibly diverse. So there's just a real variation between women. But what I really like about the following data set is that I always try to lock on as a scientist into something that is somewhat consistent, right? And so I was able to crunch the data for these 3 different studies. And the first study in the table here is my own, the one that we did back with the 24, 27, and 30 shields. And what we saw is on average was a 2 millimeter increase. And here's your 95% confidence interval, so 1.4 to 2.5. There was a recent set of data that popped up in 2022. So I took that into this table here, and they saw an average of 2.3 millimeters. This was a US cohort. And again, a really similar 95% confidence interval. Then there was a recent study, again, just from last year, that used 21 and 24 shields, and they saw a 2.2 millimeter increase. Again, a really similar 95% CI. So what this shows is that there seems to be a really consistent anatomical change, even across different cohorts in different eras and different study locations. And the fact that these 3 studies are using 3 different shield sizing approaches, but they still see this constant of around 2 to 3 millimeter increase, tells me that it is a really consistent anatomical change. This study in the middle here, which actually had somewhat the highest increase, they were actually even going down to a size 15 millimeter tunnel. So something in here is really conserved. There's going to be around at least a 2 millimeter increase, 2 to 3 millimeters perhaps, but then there's this outlier group here where these mums need to be considered when they do even go above 3. And so this is what drives the recommendation that when you're sizing a mother, that you add space to the nipple diameter that you measure before the mother pumps, before the nipple has increased in diameter at all. This is the data that's driving the recommendation to add some space to make sure that if she expands, that she's not reaching the point of a too tight fit in the tunnel. So the sizing now, I want to talk about it from a perspective of performance and from safety. So I like this quote, breast shield design and fit are important factors that can improve milk removal, comfort, and overall experience for women. And I think everyone on the call can fully agree to that statement. So let's jump into the milk removal part now and talk a little bit about performance. And then I will show you some a little bit nasty statements from the safety perspective. So in general, when it comes to performance, there is a lot of literature around that shows that for a large proportion of mums, the standard sizes are objectively performing really well. And by objectively, I mean that we reference back to their infant. So we want mums, when they use a pump, to be removing a similar amount of milk as what their infant removes. If the pump can remove a similar proportion of the available milk as the infant does, then we have the theory that they can maintain milk production, right? Maintain milk supply. We want the mum or the pump to be removing a physiologically appropriate amount of milk from the breast, and we believe the infant is the best determinant of what is a physiologically appropriate amount of milk from the breast. So the research I'm going to show you now in this next animation are all mums between 1 and 6 months of lactation. They're all in established full milk supply. They're not experiencing any problems, okay? And what you can see is that in each of these studies, the percentage of available milk removed, which is a really objective measure, it requires the mum to do a full assessment for 24 hours with her infant. It requires a ton of pre and post breast milk samples to be collected to measure the fat content. There's a special algorithm that quantifies the entire breast structure and form in terms of the synthesis rate. And then from there, we're able to ascertain how well a pump performs in a 15-minute pump session. And so we have here a series of publications that have come out over the years, and you can see that on average, they're all hitting about the desired amount of what the infant would remove. And interestingly, in all of these studies, you see they're using the standard sizes. So a 24, 24, 24 only. All those mums were fitted to 24s. 24 and a 21 was the more recent data, and a 24 and a 21 also for that recent study. So the standard sizes are on average doing pretty well, and we commonly see in lactation-related research a rule of 2/3. We see around a third of mums that could always do a little bit better, about a third of mums that could maybe be optimized. And so that's on the next slide, the real opportunity for offering specialist support, because breast shield sizing is the ultimate opportunity to tailor and personalize fit, right? So breast shield sizing comes with the real benefit of being able to sit with the mum and personalize that interface, which is a